And these resistance genes, they develop by mutation. And these genes, they can code for proteins that cause target alterations, as in MRSA, it becomes penicillin binding protein 2A, or they can lead to efflux pumps, or they are inactivating enzymes which will destroy the antibiotics. And once these genes are developed by mutation on exposure to antibiotics, then they can be transferred to other bacteria across species and across genus also. And this transfer can occur in vivo, in vitro also, in many surfaces in the hospital which are not cleaned, bedpan, moist areas, and what happens when we go and touch them? We put some of our bacteria there, pick some, then on our way to work, we have to touch somewhere else, again put some, take some, like that the microbes, they will spread, and ultimately if it spreads to me, nothing will happen to me. But if it reaches a patient on a ventilator or a catheter, then you know what will happen. And it has reached, and that is what we are afraid of, the silent pandemic of antimicrobial resistance. Today we are talking about gram-positive cocci. So about resistance in Staphylococcus aureus, almost more than 90% are resistant to penicillin. The microbes produce the penicillinase gene. And in our hospital data is in red. Our prevalence is 36% for methicillin-resistant Staph aureus. That means 64% are sensitive. That means there is no need to use no need to use the antibiotics of last resort as first resort. The other figures are all over India, 26 to 59%. Other options are also there, although there are resistant. Once you get your sensitivity report, you can choose the other options. What is important here is resistance to susceptibility to vancomycin is decreasing. And all over India, it is 1.2 to 3.6%. In 2023, BCMCH, we had, I think, one isolate of vancomycin, intermediate Staph aureus, 1 among 250, 0.4%. And resistance to linezolid, although it is just below 1%, still we have that also. That means they're all here. Just a matter of dissemination and use the antibiotic. Do you think these genes, if they develop the genes, they have it forever? Can they lose it? Yes. If you stop using an antibiotic for 6 months or so, 1 year, 2 years, then they will all shed those resistant genes. They are shed. They are all a metabolic burden for the bacteria to carry them when it is not needed. They will shed them, but 2 or 3, 5 days, 10 days, if you stop, nothing will happen. So this is the condition of your Staphylococcus aureus. How do they develop resistance? By different methods. Drug and inactivation by enzymes such as penicillinase and transferases. Modification of target, as in your altering the penicillin binding protein leading to MRSA. And modified peptidoglycan precursors mediated by the VAN-A gene. VAN-A is the most important. There are other VAN genes also leading to the VRSA. And your thickened cell wall blocking the entry of vancomycin leading to vancomycin intermediate Staph aureus. That is the one we had here. And you must remember that the method of mechanism is different, so one doesn't lead to the other. VISA and VRSA. and it can also be an efflux pump. So these are the different mechanisms by which gram-positive cocci are gaining resistance. Another important thing is in some strains, there are MEK-A regulators which slowly induce the production of protein. Therefore, when you test, it will be an methicillin sensitive, but when you treat after a few days, you may recognize that there is therapeutic failure, and that is a case for a repeat culture. The repeat it will detect. So these are not in all cases, so you just have to be wary of it, aware of it. So to sum up, Staphylococcus is there all over us, everywhere in the hospital, very easy to, it doesn't need any big enriched media to grow. Wherever you touch, it can survive for some time, and they have a propensity to develop drug resistance during treatment, and only 36% MRSA among our isolates, so 64% are sensitive. So you can use cloxacillin, and in these cases, Vanco is not superior to cloxacillin. You can use clox. Be aware of that MEK-A regulators. And linezolid resistance is coming up, vancomycin resistance, insusceptibility is coming up. Therefore, no need to use linezolid, vanco as your first resort. Keep them for your last resort. Now coming to the gut microflora, that is the enterococcus. They are important in the sense that they have lots of inherent resistance, intrinsic resistance, as well as they will acquire also new genes. Okay? And MDR enterococci well adapted to live in the gut, and they can spread their genes in the gut. Very easy to disseminate, very easy to get on your hands also. And they are donors of vancomycin resistance to gene clusters to staphylococci if they come near them. And among the enterococci, faecalis is the most common species, but Enterococcus faecium is the more resistant one than faecalis. So enterococci are intrinsically resistant to all clindamycin, cotrimox, low-level aminoglycosides, all cephalosporins, penicillinase resistant penicillins, and among the beta-lactam group, most of them are sensitive to penicillin and ampicillin, and totally resistant to cephalosporins. These are the intrinsic resistance. And acquired resistance, these microbes have acquired resistance to erythromycin and tetracycline via the target alteration as well as efflux mechanism, and they have developed resistance to susceptibility has decreased in vancomycin also. And in 2023, we had 3 isolates of VRE. 3 isolates of VRE. Just a word on LVRE. What is it? Linezolid vancomycin resistant enterococcus. This also is developing slowly. This is a new entity. We had 1 or 2 doubtful cases just 2 months back. We are going to refer it for a molecular characterization so that we are sure that it is really LVRE. And there are about 10 to 12 strains in the whole country reported. So we have to be aware of. And linezolid prescriptions in our hospital per day is about average 6 per day. I don't say it is very big, but it can be reduced. So that is how these bacteria, they develop new resistant genes, and they develop them on exposure to antibiotics. In a ward, if 1 or 2 patients are given, the microbes in other patients also will recognize that, and they will respond. All we are seeing is the response of the microbes to our use of antibiotics and biocides. Disinfectants, and also if you are using in low concentration, it can lead to increase in MICs and resistance. Once the genes develop, then they transfer them, of course, to their progeny and also to their neighbors. Very easy for a staphylococcus and enterococcus to come close. And recent research says that biofilms, once you put a patient on devices, they quickly develop biofilms. And even in vitro also, biofilms are developing in bedpans, in moist areas. They say humidity high areas, biofilms can easily develop. So the importance of presence, you should be aware that they are all present. The gene exchange is occurring. Genes have developed and they are exchanged also. So to summarize, Staphylococcus and Enterococcus, both of them are very close to us. The gut flora and the skin flora and the reservoir, we are the reservoir, they are conquering the antibiotics of last resort. And we know that because they are close to us, they can hang on to our hands and we can spread them all over the place. Therefore, the importance of scrupulous hand hygiene, scrupulous surface hygiene, and also the importance of reducing fomites. On your way to your seat in the hospital, if you have to touch many places, you'll be putting some of yours there and picking some and taking also to your patients. All these will prevent transfer of dissemination of these microbes containing the R genes. And be conscious, be an antibiotic guardian. Don't lose high-end antibiotics like linezolid, Vanco, Tico, all these as first resort. Keep it as the last resort. And laboratory studies have shown if you don't use a particular antibiotic for some months, 6 months if you don't use, they are known to shed these genes because they don't require. They are metabolic burden for them. So it is possible, there is hope. And in a hospital, asepsis should be the only style that you adopt. Be it a door or a handle, whatever. Wherever you have to touch, you will be depositing some microbes and you will be carrying some microbes. So let us all join this battle to defeat the purple superbug, the gram-positive cocci, today as we are discussing. If we don't join the battle, all of us, all cadres, then what is happening is the microbes have all joined together. They are having conferences, developing new genes, new strategies, and we are helping them to disseminate also. Gene transfer is occurring. We can't see them, but it is occurring at all corners, wherever microbes are there or wherever, whichever place not cleaned. Any questions we can take now or at the end of?
Thank you, Madam, for the very illustrative talk. We will keep the queries towards the end after the second session. Now I invite Dr. Imthiyaz to explain about gram-positive. Today we have confined to gram-positives. We haven't covered gram-negative because always we will be listening to gram-negative resistance. Over to Dr. Imthiyaz.
Good morning, respected faculty, dear colleagues and juniors. So today I'll be illustrating some examples of certain gram-positive infections which we commonly encounter in our hospital. So as ma'am has told, the two most common infections that we get to see in a hospital setting, they are either Staphylococcus aureus or Enterococcus. How to treat these infections, especially when they are harboring some multi-drug resistant genes, we will be discussing all these cases today. So at first, I would like to start off with this saying of Dr. Fleming. We all know that he had discovered penicillin. So at that point, he was well aware of the misuse of penicillin, and he also had foretold that the indiscriminate use of these drugs may lead to rise of antimicrobial resistance in the future. And in the current scenario, we all know that there are very less organisms which are still, as of now, sensitive to penicillin. So we'll start off with a case. Our first case, it's a 50-year-old male, known case of chronic kidney disease on maintenance hemodialysis. He comes to the emergency with fluid overload. He's put on NIV, given oxygen support, started on diuretics, and he's taken up for dialysis. So the access is through a left-sided, through a left jugular catheter, and on day 3 of his hospital stay, he develops high-grade spikes, high-grade fever spikes. So now infective workup has been sent for this patient. Chest X-ray, it shows features of fluid overload. There is no pneumonia-like picture. The urine routine and the urine culture, they are not suggestive of an infection. Blood cultures have been sent. They have been sent from 2 sites. One from the dialysis access site and another from a peripheral blood site. So this is a proper way of sending blood cultures. Whenever you send blood cultures, you should send it in an aseptic manner, and you should try to get at least two sets. If there is a central catheter, you take it from there. Along with that, you take it from a peripheral site. So we have to start antibiotics for this patient. As of now, we are having no culture report, so we'll start him on empiric antibiotics. Generally, what do we start? We start with a gram-positive cover and a gram-negative. In this case, the gram-negative would be a meropenem, and the gram-positive coverage, it is given by Targocid, which is teicoplanin. So this is empirically we have covered for both gram-positive and gram-negative organisms. After 2 days, the culture report comes, and this is the culture report. So we can see that it has grown Staphylococcus aureus, and it's in brackets, it is written that it is MSSA. So does anybody of you know how we say an organism, it is a MSSA or a MRSA? MRSA being methicillin resistant, MSA being a methicillin susceptible. So we use certain markers actually. In this case, we have used the cefoxitin. So before going to that, so here we see that the Staphylococcus aureus, it is sensitive to cefoxitin. So it is not MRSA, it is MSSA. So at this point, would you like to de-escalate the antibiotics? Would you like to give a much lower antibiotic rather than giving this higher grade antibiotics like meropenem and Targocid? So what would you give to this patient? So now we have a culture, so now we can go forward and give him a culture directed antibiotic. No longer we need to continue the empiric therapy. So before going into what antibiotic to give, just a brief overview of how resistance in Staphylococcus aureus arose. So basically in 1944, when the use of penicillin was first started, within 20 years we can see that this Staphylococcus aureus, they started developing resistant strains. To counteract this, another new group of drugs, they were created. So this resistance is actually due to the production of certain enzymes by the Staphylococcus aureus, which is penicillinase. They will come and they will break down the penicillin. So this led to the creation of certain penicillinase stable drugs. For example, dicloxacillin, oxacillin, nafacillin, and methicillin. So methicillin was one of the drugs which was used at that point of time. But once methicillin was introduced, again it was seen that within a few years' time, this Staphylococcus aureus, they developed resistance against this methicillin as well. So these strains, they were called as MRSA, methicillin resistant Staphylococcus aureus. Again, further drug development was attempted. It was discovered that vancomycin is effective against this MRSA. So now the usage of vancomycin increased. The increased uses of vancomycin obviously led to selection of certain resistant strains. It was seen that another group of organisms developed resistance now. This was the vancomycin resistant enterococci, which is there in our gut. And after the 1990s, we also saw that slowly the vancomycin resistance started to develop in this MRSA strains as well. So immediately we saw the vancomycin intermediate Staphylococcus aureus, and in the early 2000s, we saw the appearance of vancomycin resistant Staphylococcus aureus. So how we know that uh, the initial resistance which developed in Staphylococcus aureus, it was due to the production of penicillinases, which was destroying the penicillin, for which we had developed certain penicillinase stable drugs. But this MRSA strain, there the penicillinase resistant drugs, they are not working. We are giving them dicloxa, cloxacillin. It is not working. What is the mechanism in such cases? So we all know that gram positives, they have a very thick, they have a very thick peptidoglycan wall. So the synthesis of this wall, it requires certain transpeptidases and transglycosidases. These are enzymes which are located on the walls of this gram-positive organisms. So these are these enzymes. So these are called as the penicillin binding protein. They will cause the elongation of this peptidoglycan wall. So the penicillin, if it is it is a sensitive strain, the penicillin will come and bind to this penicillin binding proteins and stop this peptidoglycan wall elongation. But in MRSA, what is happening? In MRSA, what is happening is there is an altered penicillin binding protein. So we can see this PVP2A. So in this PVP2A, this penicillin, it is unable to bind to this. And because it is unable to bind, it is unable to inhibit this. So peptidoglycan wall, despite the presence of an antibiotic in its environment, the peptidoglycan wall, it is not hampered. They go on continuing creating this peptidoglycan wall. The bacteria is thus not killed. So this is generally, whenever they have this MEK-A gene, they will develop resistance against this penicillinase stable drugs. For example, in methicillin. So these become MRSA, MRSA. So currently, as of today, methicillin is no longer used. Why? Because if you give it to a patient, they will develop interstitial nephritis. It's a very toxic drug. And it is not used in microbiology labs as well. So we all know that resistance in microbiology labs, what do? We do a disc diffusion test where we put antibiotic discs and see the zone of inhibition. So rather, we use certain other markers. What are the markers which we use? We use cefoxitin and oxacillin. Cefoxitin is the most commonly used. It is the most stable of this two. So whenever you get a culture report and it shows it has grown Staphylococcus aureus, cefoxitin sensitive. Cefoxitin, it's a biomarker for MRSA resistance. If it is sensitive to cefoxitin, it is not an MRSA. So in such cases, you can give a lower antibiotic. So now, this particular case which we were discussing, we saw that the blood cultures, it had grown an MSSA. He was started on meropenem and teicoplanin. So in this case, we would try to de-escalate the antibiotic. So to what antibiotic would you like to de-escalate? What are the options we have, and why do we need to de-escalate in the first place? Why not give a higher end antibiotic? So it has actually multiple studies have been done where they have evaluated the performance of these higher antibiotics, these glycopeptides like vancomycin, teicoplanin. These are glycopeptide antibiotics, and it was seen that compared to those patients who are receiving a lower antibiotic, for example, cloxacillin, oxacillin, so there is actually mortality benefit with the usage of these lower antibiotics, cloxacillin, dicloxa, oxacillin. It has been seen that there is 79% more mortality. The adjusted mortality percentage is 79 times more if you give vancomycin or teicoplanin to an individual who is having MSSA bacteremia. So whenever you find a culture which is showing MSSA and the patient is receiving these glycopeptides, vancomycin, teicoplanin, you should make an attempt to de-escalate the antibiotic, give him this lower antibiotics, for example, cloxa, dicloxacillin, or any first generation cephalosporin. So even we can argue that piperacillin tazobactam, with respect to its gram positive coverage, it is a lower down antibiotic compared to vancomycin, teicoplanin. So can we give piperacillin tazobactam in such cases? So studies have also been done utilizing these antibiotics. For example, there was this one study which has studied nafacillin, oxacillin, cefazolin, peptaz, and fluoroquinolone. It has been seen that piperacillin, tazobactam, and any of the non-first generation cephalosporins. Non-first generation cephalosporins, what they can be? They can be ceftriaxone, cefotaxime, cefepime. So whenever we are using a higher generation cephalosporin or a higher end antibiotic, for example, peptaz, so there is actually there is a mortality benefit if you use a lower generation cephalosporin or a lower down antibiotic. So generally we would prefer something such as a cefazolin. It's a first generation cephalosporin. So this particular patient who had received meropenem and teicoplanin, so the teicoplanin, it was stopped and the patient was started on cloxacillin. This was the dose which was given to the patient. So whenever you see a culture sensitivity report of a patient who has grown an MSS, you will notice this, that all of them, they mention that vancomycin is not preferred. Why is it not preferred? Because these giving this penicillin stable drugs, it actually has a mortality benefit. So never give vancomycin or teicoplanin to those individuals who are having MSSA. Now we'll change the case a bit. So the same case, it comes to you. However, this time there is a difference in the culture sensitivity pattern. So we can see the cefoxitin here, it is sensitive. Cefoxitin is one of the biomarkers for MRSA. But here we again had discussed that we can use oxacillin also. Oxacillin here, it shows resistance. So these next two cases which I will discuss, they are not that common in our setup, but you should be aware of it. So we see that there is a discordance. The cefoxitin is sensitive, but oxacillin is resistant. So what can this be? So this is actually something called as the BORSA, borderline oxacillin resistant staph aureus. Here, what happens is the penicillinases which the bacteria is producing, there is hyperproduction. And because of this hyperproduction of these penicillinases, the MIC of oxacillin, it increases further such that they become borderline resistant. It is not commonly seen. Around 5% of the Staphylococcus aureus cases, they may show this kind of a culture phenotype. However, the treatment actually changes in these particular cases. So, if suppose we are using only one disc, we are either using cefoxitin or oxacillin, it becomes very easy for us to misdiagnose this infection. We might either diagnose it as a case of MSSA based on the cefoxitin sensitivity or an MRSA based on the oxacillin sensitivity. So yeah, BORSA cases, we look at the cefoxitin. The cefoxitin, it is sensitive. We can label it as MSSA, or if only oxacillin was done, oxacillin sensitivity, which becomes resistant because of the hyperproduction of the penicillinases, we can label it as an MRSA infection. So how do we treat these BORSA infections? So we know that large amount of penicillinase they are producing actually. So in this organisms, in such infections, if it is a non-severe infection, then we can add a beta-lactam inhibitor. Beta-lactam, they will inhibit this penicillinases. So we can use, in non-severe infections, we can use a beta-lactam plus a beta-lactam inhibitor. For example, ampicillin sulbactam. However, if the patient is having very severe infection, then it is better to treat them as MRSA infections. We'll discuss what to give in MRSA infections later on. Another thing which you might confuse with, because there might be a discordance between the oxacillin and cefoxitin, is the MEC positive MRSA. So we had discussed MRSA, because of the MEC-A, they produce an altered penicillin binding protein which is PBP2A. Here what happens in MEC-C, that PBP2C is produced, and this PBP2C, it is actually has a higher affinity for penicillins. Because of this, it can be inhibited by the penicillins. In vivo, it will be inhibited by the penicillins, but it will not be inhibited by the cephalosporins. So whenever you see the results of the AST, you will see cefoxitin, it is resistant because it is not binding so well with the cephalosporins. However, it has bound well with the oxacillin, and oxacillin has inhibited it. So based on this, oxacillin, you might label it as MSSA, and for cefoxitin, looking at the cefoxitin AST, you might label it as MRSA. So you should be aware of this. And such infections, they are to be treated on the same lines as that of an MRSA infection. So just to summarize, whenever an organism is harboring genes like MEC-A, MEC-C, it's a MRSA organism, and here you give glycopeptides. For example, you can give vancomycin, teicoplanin. If it is BORSA, borderline oxacillin resistance is present, non-severe infections, you try to go with a beta-lactam inhibitor combination. If it's a very severe infection, go with glycopeptides. And whenever you encounter MS as a bacteremia in your practice, it is better to switch to a lower-end antibiotic, lower-end beta-lactam. Another one of the commonly encountered scenarios, at least in very small hospitals, so nursing homes. So what happens is, like for example in this case, a 40-year-old diabetic who is not taking his medications properly, he is having uncontrolled diabetes, he is now come to your surgical OPD with a wound on the sole of his feet. You examine the wound and you see that it is less than 2 centimeters in size. You ask for history of any systemic signs, whether he is having fever or not. So he denies any such systemic symptoms. So what do? You take swab from that wound, you send it for culture, you debride the wound, and you have added certain antibiotics. So in this particular case, this particular individual, he had added linezolid as well as clindamycin. He has given gram-positive coverage. However, my question is this a rational antibiotic choice in this particular patient who has come with a less than a very small wound on his feet? He is diabetic. So yes, this is not a correct antibiotic choice. So what would be a correct antibiotic choice? So to decide on what could be the correct antibiotic choice, I would just like to refer to our institute's antibiogram. So we can see in our institute, for skin and soft tissue infections, a majority of them, they are caused by Staphylococcus aureus. And this patient, you encounter him on an OPD setting. So he is coming from he is harboring a community-acquired organism. So for community-acquired organisms, what does our data say? So our antibiotic policy, it says that for mild diabetic foot infections, if you want to give oral antibiotics, dicloxacillin is sufficient enough. However, if you feel that there is some need for giving IV antibiotics, you can get amoxiclav or cefuroxime. So here, no place it is mentioned that you have to give linezolid, you have to give teicoplanin. These are antibiotics which cover gram-positive organisms, but this is a very low-grade infection, number one. This is not a severe infection, and it's a community-acquired infection. There is no need to utilize such high-end antibiotics in such cases. Another thing which I would like to emphasize on, not specific for diabetic foot infections, but for any soft tissue or skin infection in general. So the Infectious Disease Society of America, they had released these guidelines in 2011. So, for example, in your practice, you encounter some skin and soft tissue infections. For example, you see some abscess. A patient has come to you with abscess, and there are no systemic signs per se. So in case of simple cutaneous abscess, you just do an incision and drainage. There is no need to give any antibiotics. When will you give antibiotics? You will give antibiotics in those cases where the abscess is very deep-seated, you are unable to drain that abscess, or there are multiple abscesses, or there is extensive disease, or the patient is developing cellulitis and that is expanding, or the patient has developed systemic signs of infection, or you have done incision and drainage, however, the patient is not responding. So in such cases, you will go with you will give the patient antibiotics. Otherwise, incision and drainage is sufficient enough. What antibiotics you can use? So we would prefer to use clindamycin or Septran in such cases. Linezolid, you would prefer not to use because of the chances of selecting for antibiotic resistance in such cases. We'll discuss another case. So a 54-year-old female, known case of chronic kidney disease, on maintenance hemodialysis with a right-sided permacath. She has come to the emergency with high-grade fever and chest pain for 15 days. These are the vitals. So you send for routine fever workup. You do for the CBC, the liver and kidney function. You look at the chest X-ray, the urine cultures, and for acute febrile illnesses, you test. All of them are negative. So now you go for the second-tier investigations. You have sent a blood culture, the reports of which are awaited. You also go with a 2D echo. When you do a 2D echo, you see that he has two vegetations on the tricuspid valve. One of them is measuring 18 by 16 millimeter, the other is 18 by 18 millimeter, and there is a mild tricuspid regurgitation. The ejection fraction is good in this patient. So now you know that this patient is having infective endocarditis. So you again send for repeat blood cultures as per the IE protocol, and you remove the permacath. Why do you remove the permacath? Because it's a nidus for infection. That possibly is the source of the infection. We will discuss MSSA in general what is to be done for Staphylococcus aureus bacteremia, but one of the steps, whenever you find that the patient is having bacteremia and he has some IV line in situ, the first step would be to remove that IV line, because that it is very much plausible that that is the source of your infection. Now your blood culture reports come. So here you see it is Staphylococcus aureus, however cefoxitin is resistant. It is sensitive to most other antibiotics, teicoplanin, vancomycin, linezolid, Septran, ciproflox. So in this particular case, again, what antibiotic would you like to give? So this is a case of MRSA. Which antibiotic would you choose? So generally what people would do is they will start the patient on vancomycin in this patient. However, do you think that we can give this patient some other antibiotic instead of vancomycin? So this is a case of infective endocarditis, which is obviously a complicated Staphylococcus aureus bacteremia. So in such cases, though your culture sensitivity, it might show that the organism is sensitive to fluoroquinolone, tigecycline, Septran, quinpristin, dalfapristin, you will not give. So these drugs, they are never to be used as monotherapies for complicated. We will come later. What is complicated staphylococcal infection? What is uncomplicated staphylococcal infection? So whenever there is complicated staphylococcus infection, these drugs, you'll never give them in monotherapy. You can add them to a primary regimen of, say, vancomycin or teicoplanin, but never as monotherapy. So this patient, he was started on injection vancomycin. And you know, infective endocarditis, the treatment duration is very long. It can extend for 6 weeks or even more. So he's receiving antibiotics for a prolonged duration of time. However, the patient after 2 weeks, you see that he's still having these fever spikes. Inflammatory markers, the ESR and the CRP, they are raised. And his blood cultures, they are also being repeated on a daily basis. So why do we repeat blood cultures in infective endocarditis, especially if it is Staphylococcus aureus, caused by Staphylococcus aureus? So in infective endocarditis caused by Staphylococcus aureus, we need to document the clearance of infection, because that will determine the duration of antibiotics. It is said that you have to give antibiotics for 4 to 6 weeks after blood cultures have become sterile. To document the sterility of blood cultures, you will have to send for blood cultures every 1 to 2 days. So his blood cultures, they were being repeated. And now again we see, again it has grown MRSA, cefoxitin resistance. However, now this time we see that the MIC for vancomycin, it has increased. Vancomycin has become resistant. Why it has become resistant? It has become resistant perhaps because of the prolonged duration for which the vancomycin was being given to this patient. So perhaps the vancomycin, it was not reaching the targeted concentration in this particular individual. So these kind of scenarios you may come across. So for vancomycin, ideally whenever you are giving the patient vancomycin, you should try to do a TDM, a therapeutic drug monitoring, because it will tell us whether to increase or decrease the dose of vancomycin. So now we see that this patient, he has developed MRSA, he has MRSA infection and vancomycin is resistance. Now what to do? So before I proceed to the options that we have, just a brief word. So whenever, how do we say that it is vancomycin resistance, vancomycin intermediate, vancomycin sensitive? We actually look at the MIC, the minimum inhibitory concentrations for vancomycin. If it is less than 2, we label it as a VSSA. If it is between 4 to 8, it is a vancomycin intermediate, and more than 16, it is VRSA. in via intermediate, vancomycin intermediate, what happens is due to the prolonged exposure of the vancomycin, there is something called as the MIC creep. The MIC slowly it increases. This is due to multiple mutations which keep on happening because of the antibiotic exposure and selection for those mutations. This will give rise to this vancomycin intermediate Staphylococcus aureus, and it might also give rise to something called as H visa. H stands for heteroresistance. Just a few words on H visa. So, heteroresistance, what we see that the collection of microorganisms, some of them will have a very low MIC, some of them will have a very high MIC. This is heteroresistance. So, due to prolonged exposure to vancomycin, some of the population, they will develop higher MIC, some will not. So this also falls under the spectrum of this visa organisms. And finally, VRSA, vancomycin resistance. It is due to this particular gene, the VAN gene. So Staphylococcus aureus, it had actually obtained this VAN gene from VRE, vancomycin resistant enterococci. When I was showing you the history, vancomycin resistant enterococci was the first to appear. Vancomycin resistant Staphylococcus aureus appeared later. And it was due to this acquisition of this VAN gene from VRE. So whenever we are getting anything other than VSSC, we are getting visa or VRSA, it is better to stop the vancomycin. We'll give a higher on antibiotic. So the antibiotic which we choose and which is available in our country, though it's very expensive, is daptomycin. So we give the patient daptomycin 10 mg per kg. Daptomycin, it has actually two dosing strategies, normal dosage and a high dosage. The normal dosage, you give it as a 6 mg per kg per day, and the higher dosage, it is 10 mg per kg per day. So we started this patient on daptomycin, and after 2 weeks the patient becomes afebrile and his inflammatory markers, they are coming down. Blood cultures we had repeated, and now blood cultures, they have become sterile. So we saw how by giving vancomycin to the patient, the vancomycin's MIC is increased. So it's a bad thing for us physicians. It is leading to the development of resistance. But there is another effect which comes into play because of this, which is called as the seesaw effect. So MRSA, whenever they are exposed to increasing concentrations of daptomycin, vancomycin, teicoplanin, here the MIC creep will happen. They will develop resistance to these organisms. However, the lower end antibiotics, the lower end beta-lactams, their MICs, they will decrease such that they will start appearing to be sensitive to those stains. So this is called as the seesaw effect. Resistance develops for the higher antibiotic, but the lower antibiotic, it becomes more sensitive. It becomes more susceptible. So we can actually utilize this in such cases where we see that we have given monotherapy with vancomycin, fever is not going down, the patient is still not able to clear off the infection. So this is what it would look like. For example, initially when you isolated the MRSA, the MIC, the minimum inhibitory concentrations, they were lower for daptomycin, vancomycin, teicoplanin. It was very high for penicillin or cefoxitin. Say after 2-3 weeks, you are again isolating the same organism. However, the AST, it has changed. Daptomycin, vanco, teico, their MICs have increased. Penicillin, cefoxitin, there has decreased. So this happens due to there is some perturbation in the cell wall building machinery. So in such cases, which is we can label this as a refractory bacteremia. In cases of refractory bacteremia, we can actually combine this daptomycin with this beta-lactams actually. So resistance, whenever resistance will develop, increased susceptibility will be there, and anyways the microorganism will be inhibited. So this combination therapies, it is actually advocated for refractory bacteremia. In combination therapies, we combine daptomycin with all these drugs. So you can see that beta-lactams is there. Though the organism might show resistance on the initial AST profile which you have seen, beta-lactams might be resistant, but still it is better to add a beta-lactam in such cases of refractory bacteremia. Gentamicin, rifampicin also we can add in such cases, but generally they are not added because of the side effect profile. Gentamicin, it is very nephrotoxic. Rifampicin, it can cause hepatic side effects. So we had discussed the main MSSA, MRSA organisms, the VRSA, VSSC, what antibiotics to choose from. Now just discussing in general about Staphylococcus aureus sepsis, about Staphylococcus aureus bacteremia. So whenever you encounter such patients where the patient is having Staphylococcus aureus bacteremia, you will do undertake certain steps. You will do a minimum evaluation which includes a thorough history and exam. In history, you will ask for the risk factors of MRSA. What are the risk factors of MRSA? If he has any recent hospitalization, any recent surgeries, if he is undergoing maintenance hemodialysis, he has a catheter in situ, if he has been colonized by MRSA, or he has a past history of being affected by an MRSA organism. You will do a thorough exam. In the exam, what will you do? You will look for any lines, if they are present, any catheters, any hemodialysis access site. You will auscultate the heart for any murmurs. You will palpate the spinal area because there might be some spinal abscesses might be present. You will look for the skin for any abscesses which is present. You will examine the joints. There might be some septic arthritis. So actually, Staphylococcus aureus, it has a propensity to cause metastatic infection. So basically, we are looking for all the sites of this metastatic infection. You will repeat blood cultures for this patient who has bacteremia. Why? Because obviously we need to document clearance of this Staphylococcus aureus bacteremia, and you will do a transthoracic echocardiogram. So accordingly, you will label the patient as a low risk or a high risk. So who are the low risk individuals? Low risk individuals who have no predisposing host factors. We have done an echo, it has come negative. The blood cultures, they clear within the next 48 hours, and there is no signs of metastatic infection. However, if the patient has any predisposing risk factors, there are some clinical features which tell you that he might be having infective endocarditis. On examination, you think that metastatic infection is present. He's having certain implanted prosthesis. He happens to be an injection IV drug abuser. Or blood cultures, they still have not become sterile after 48 hours. You label this as as a high risk Staphylococcus aureus bacteremia, and then you will do the management of the patient, which includes two things. Number one, you have to reduce the source control. So the source of the infection, you will have to reduce that. How do you do that? If you are seeing there is any abscesses, there is any septic arthritis, you will have to drain all those things. If there are any implants, there are any central lines, there are any CIEDs in the patient, you'll have to remove them. And then antibiotics. We have discussed previously what particular antibiotic to give. We'll here now discuss the duration. So in uncomplicated cases, what you do is you give a lower duration of antibiotics. You give it for only 14 days. But in complicated cases, what do? You give it for a prolonged period. So as discussed previously, you'll give it for at least 4 to 6 weeks in such cases. So just to summarize, so if the patient is having MRSA infection, which is not life-threatening, these are the particular drugs which you can give, Septran, Rifampicin, or tigecycline. However, if the patient is having very life-threatening infection, or he's having bacteremia, very severe infection, then you'll have to go with vancomycin and preferably combine it with some other drug in such cases. So we have discussed Staphylococcus aureus. Now I'll just be discussing in brief about enterococci. So enterococci is the second most commonly encountered organism in tertiary care hospital with regards to gram-positive infections. So we know that it can be found in the GIT. So there are actually two common species, Faecalis and Faecium. So generally, they either cause UTI, endocarditis, bacteremia, or wound infections. These, most of the organisms, they cause these infections only. Of this, actually, we will discuss endocarditis because that's the antibiotic therapy here, it becomes a bit complicated. For the rest of them, the antibiotic therapy is quite simple enough. So for Faecalis, which is the more commonly encountered organism in our setup, so it is more susceptible compared to Faecium. And we see that Faecium, it is the one which generally harbors more resistant genes. It is the one which is more resistant. However, there is one particular antibiotic, vinpristin, dalfopristin. Faecalis, it is resistant to that. Faecium, it is susceptible. And in fact, it comes in the management algorithm of Faecium, vinpristin, dalfopristin. Of these two organisms, though Faecium is the more resistant it is the more resistant of the two organisms. The infections, however, they are not as virulent as compared to that caused by Fecalis. So in non-complicated cases of Enterococcus, non-complicated as in infections where there is no endocarditis, there is no severe infection, antibiotic monotherapy according to the culture sensitivity is sufficient. However, in complicated cases, for example in endocarditis, the management becomes a bit difficult. So just a few words on this vancomycin resistance. So we had discussed that after the introduction of vancomycin for this MRSA infections, we saw vancomycin resistant enterococci. So what happens is, again the peptidoglycan, when it is being synthesized, it is using precursors. So these precursors are D-ALA. The transpeptide the transglycopeptide they are synthesizing the peptidoglycan using these precursors. However, when we give vancomycin to the patient, vancomycin, it attaches to these precursors and they will not allow it to be imbibed in the peptidoglycan wall, these D-ALA residues. However, when a vancomycin, when it gets this VAN gene, what will happen is instead of utilizing D-ALA, they will start to utilize D-ALA-D-LAC, which the vancomycin won't be able to attach to. So now this precursor, it is still free. It will go and create the peptidoglycan wall. So before, so we had told that in uncomplicated cases, monotherapy is sufficient. However, in complicated cases, we'll have to use some sort of a combination for these enterococcal infections. So what can we combine this with? One of the options which we have is beta-lactams with aminoglycosides. Why? Because they will give rise to synergy. So we give beta-lactam to the patient. This beta-lactam, it will inhibit the cell wall synthesis. Because of this inhibition of cell wall synthesis, the permeability will increase and more of aminoglycosides, they can go inside the cell and they will inhibit the protein synthesis. So two of the commonly used antibiotics for enterococcal infection, it is actually gentamicin and streptomycin. Another combination which we can use is two beta-lactams. So for example, ampicillin and cephalosporin. In this case, how does it work? So ampicillin, we know that it preferentially binds to penicillin binding protein 4 and 5. We saw in the previous, in the diagram, that there are 4 penicillin binding proteins. Ampicillin will bind to PB4 and PB5. And if we give ceftriaxone, cefotaxime, they will bind to PB2, PB3. So now all the penicillin binding proteins, they have been saturated. This synergistic effect will inhibit the growth of enterococci. So in general, enterococci, they are resistant to cephalosporins in general. However, there is some susceptibility to this third generation cephalosporins, ceftriaxone and cefotaxime. So, it doesn't mean that it is completely susceptible. There is some susceptibility is there. So you should never give ceftriaxone or cefotaxime as monotherapy in such cases. So now we'll discuss the treatment options in brief. So for E. fecalis, so we had discussed E. fecalis, which is the more common one. It is the more virulent one, but it has lesser MDR genes. So we will check for something, we will try to give the patient a combination of ampicillin plus aminoglycoside. For that, we will check something called as a high-level resistance to aminoglycoside. I'll come to that later. So if we see that high-level resistance is not there, HLR is not there, we will combine it with an ampicillin with an aminoglycoside. So the Heart Association, they recommend the combination of ampicillin and aminoglycoside if the kidneys are working fine and if high-level resistance is not there. If it is there, then we'll have to combine ampicillin with a ceftriaxone, basically 2 beta-lactams. So here we can see whenever the HLR is present, we have combined ampicillin with ceftriaxone. These are some of the other combinations which we can use. We can see that 2 beta-lactams are being used in this case. Again, 2 beta-lactams are being used in this case. So what is high-level resistance to aminoglycosides? Aminoglycosides, they are resistant in this case. The normal resistance, the MICs which we see. High-level resistance is for increased concentrations. You can see the very high concentrations of streptomycin and gentamicin when they're actually resistant to such high concentrations also as given by the lab. we will call them as having high level resistance to aminoglycosides. So whenever they are having high level resistance, that synergy that we saw between beta lactam and aminoglycosides, that won't be there. The synergistic effect will be abolished. So this high level resistance, it is generally caused in case of gentamicin, it is due to this aminoglycoside modifying enzymes. And when this is present, you cannot use gentamicin, you cannot use tobra, netyl, kanamycin. For streptomycin, it is caused by a different mechanism due to the mutation in 30S or due to the presence of the streptomycin adenyl transferase enzyme. So HLR, whenever you get, you'll have to inquire for both gentamicin and streptomycin. It doesn't mean that if gentamicin is having HLAR, streptomycin will also have it. And finally, for Fecium we know it is the more resistant of the two. So generally, this ampicillin we won't be able to use in such cases. So in such cases, we go directly with linezolid, or we combine daptomycin with another beta-lactam agent. Even if ampicillin we are giving, then we have to give him a very high dose of ampicillin and combine it with an aminoglycoside. High dose as in ampicillin, the normal doses, it is per day 12 grams we can give. High dose meaning we can go up to 30 in such cases. We had discussed that enterococcus, they can also cause UTIs. So for example, if the patient is just having cystitis, then we can also use nitrofurantoin or fosfomycin. However, if the patient is having a very severe infection, for example, endocarditis, in that case, we will have to use daptomycin, and we'll have to use it as a combination. Daptomycin, we either combine it with beta-lactam or beta-lactam plus another aminoglycoside based on the AST pattern which we get. However, keep in mind, daptomycin, whenever you are giving it, it never works on the lung. So the surfactant which we have in the lung, it will deactivate this daptomycin. So for any pulmonary infections, if you're giving daptomycin, you should not give it. It won't be effective there. And whenever you give daptomycin to the patient, there will be a slight raise in the CPK levels. And in certain cases, the patient may develop eosinophilic pneumonia as well. So with that, I come to the end of my presentation. I just want you to remember this. For MRSA, we give vancomycin. But with prolonged therapy, there will be an MIC creep, so we will have to keep that in mind. Daptomycin, not a commonly used drug, but whenever you're using it, you should always send for repeat CPK levels and see if the patient is not developing eosinophilic pneumonia. Enterococcal infections, severe infections, complicated infections, give dual therapy with either ampicillin with ceftriaxone or ampicillin with aminoglycosides. And finally, whenever you're giving antibiotics, you should try to use them judiciously and de-escalate them whenever you can. With that, I'll come to the end of my presentation. Any questions?
Oh, thank you, Imthiyaz, for a good presentation. I saw the case that you have discussed about a case with vancomycin MIC of 2 milligram per liter. This patient finally had an MIC creep, and MIC went up to 4 and then later to 8 milligram per liter. So we have seen in patients with an MIC of 2, thank you, that's a good presentation. I mean, I did not congratulate on your presentation, thank you. So when we see a high MIC of 2, it's actually susceptible. But unfortunately, in majority of patients, when we do TDM, we actually see that the concentrations of vancomycin, which is achieved by the normal doses of 1 gram BD, will not achieve target concentrations.
Yes, sir.
When the MIC is 2. So that inevitably leads to the resistance and
Yes.
MIC creep. So if we see an MIC of 2, even though it's susceptible, it's better to actually, if there is a facility to do TDM, please do that. Otherwise, you may have to consider combination treatment.
Sir. So the issue with vancomycin, at least in most of the Indian setups, is whenever we are giving vancomycin, TDMs becomes very necessary. It becomes very important. So if we are unable to do TDM, we are unable to know that whether the therapeutic concentrations in the blood it is being achieved or not. Certain times, certain clinicians, they will, based on the clinical response, they will label this case as a VRSA. So it might not be that the patient is having VRSA. Subtherapeutic levels are being achieved, so definitely TDM is required in such cases. If you don't have the facility for TDM, I think in such cases, go with teicoplanin in such cases where you are unable to do a TDM for vancomycin.
Yeah. In a clinical practice, we go according to the laboratory data regarding the selection of the antibiotics. But clinical parameters, when you take into consideration, many of the antibiotics may be resistant to the organism, but we take a decision according to the clinical and vivo and vitro studies.
Yes, sir.
So we forced to take some decision in spite of the resistance, we continue the antibiotics. So what is your idea regarding that? Second is whether the severe infections, whether you need a procal or a blood culture, which is more important in taking a decision about the discontinuation of the antibiotics.
So the first question, perhaps we are getting we are treating an infection, the clinical response we are getting, and however the organism it is showing resistance. In such cases, if the patient is showing improvement, sustained improvement, the clinical parameters they are improving, the inflammatory markers they are going down, then there is no requirement to change the antibiotics in such cases. So what we are actually seeing here, that is the in vitro data we are seeing. And then based on the in vitro data, we are making assumption that this will be resistant, this will be sensitive. But what actually is having in vivo, that we are not 100% sure of in such cases. So if you are getting any response in such cases, then it is better to continue the same antibiotics. So actually the ITSA 2024 guidelines for gram-negative infections, they have mentioned this. So in certain cases, gram-negative cases, patients having a CRE, so if the patient is responding to a lower-end antibiotic, for example, piperacillin tazobactam, though they are showing the phenotype of a CRE, but they are responding, then it is advised to continue that antibiotic. This recommendation was given specifically for gram-negative, not for gram-positive. But in general, I think we can extrapolate this to gram-positive organisms. Sir, the second question, sir, if with regards to escalation, de-escalation of antibiotics, so basically, whenever we are starting antibiotics or escalating antibiotics, they should always be with regards to the clinical condition of the patient, not the lab values. For example, even if the lab values are showing that the patient is not worsening, but clinically the patient is worsening, it is better to start antibiotics then and there. Procal, sir, its utility is more in de-escalation of antibiotics. So, for example, we have started antibiotics for the patient. There is some clinical response in the patient. And at this point, we are wanting to de-escalate antibiotics, but perhaps we are not very confident, very sure whether we should de-escalate the antibiotics or not. We are in a fix. So in that case, sir, I think we can utilize procalcitonin. So procalcitonin specifically for gram-negative organisms, when it decreases to a value of less than 5, or it decreases by more than 50% in the in the previous 24 to 48 hours, then we can know the burden of infection which led to the rise in the procal. That has come down. But for that, obviously, the patient should be clinically stable. Clinically, the patient should be improving. So that can help us in decreasing the duration of antibiotics. Procal, it will help in antibiotic stewardship in that way, by decreasing the duration of antibiotics. However, if the patient is still, for example, symptomatic, the infection, the symptoms, they have not gone down. So then in that case, we will not de-escalate the antibiotics. The clinical condition of the patient should be the most important thing in deciding the escalation and de-escalation of antibiotics. Procalcitonin, it will just support, it will help in supporting this particular decision. Procal specifically for de-escalation of antibiotics.
Thank you for the excellent presentation. Just a few questions. Azithromycin versus clarithromycin in mycoplasma infection. Any indication one over the other?
So most commonly, sir, we use azithromycin itself. Clarithromycin, sir, I'll have to look into the data for that.
Why we asking is many times we get prescription when azithromycin is stopped and clarithromycin is started, and it's a prolonged course, more expensive, difficult to take. Is there any added advantages? What the question is? We don't believe any data is suggesting that these are both very similar in the spectrum. Next thing is whenever a new drug comes to the market, the prescriptions goes up. So Faropenem is something which had come in as an oral drug. Where will you use it?
So the data regarding Faropenem, so it doesn't have any added benefit over this the existing carbapenems, Faropenem. And so based on the, I think 1 or 2 studies which we had looked quite, I think 2-3 years back, so there was no actually added benefit of Faropenem over this existing carbapenems.
So being it available as an oral preparation, people tend to de-escalate it to Faropenem. Is it justified, or would you prefer going?
So actually the studies which we had seen, sir, I'm not aware of the current recent studies as of now, sir. So it was no better than yes, piperacillin tazobactam. So regarding the antibiotic coverage which was being provided and the response of the patients. So actually it was no better than piperacillin tazobactam, and I think it was inferior to this existing carbapenems. So certain people, they are utilizing it as a step down therapy. Sir, in such cases, I think we should go with the AST report of the patient and stick to the existing beta lactams which we are having. Faropenem, I don't think it's being commonly, the AST for Faropenem is also being provided. And it's a newer drug, sir. We are not having much studies, and none of the existing guidelines also, they are speaking for the introduction of Faropenem. So the last 2024 ITSA guidelines, so they have also not mentioned regarding the utilization of Faropenem. So based on existing literature, so there is not much utility in the provision of Faropenem.
Last one is, there seems to be a rise of resistant mycoplasma. A lot of cases are getting reported across the state. Right now, Cochin is also having. So how do you clinically think about a resistant mycoplasma, azithromycin resistant mycoplasma? How do we go about it?
So basically the options for us, so we prefer giving azithromycin to such patients. The other option would be doxycycline in these patients. So I think in that cases, sir, it is okay for us to go ahead with doxycycline in such patients. Clarithromycin, I am not sure of the data. I'll have to look that up. I'll look into it and let you know.
Sure. Thank you.
The last recommendation, still it is azithromycin. And regarding pediatric age group, up to 21 days safely can be used in pediatric group without any adverse events like tooth discolorations, recent recommendations. So with the judiciously can select.
Thank you. Any more questions? So thank you for the excellent presentations, Marina ma'am and Dr. Imthiyaz. They had given insights to the management of gram-positive cocci, and Dr. Imthiyaz have mentioned about the watching the MICs and also on what else? Management of Staph aureus bacteremia and Enterococcus endocarditis as well. So thank you so much. Have a good day.